I want to talk to you about is the real excitement we have in Ontario about what we see as a transformation, and I know that's a tired word, it's used all the time, but a real change. Fundamental change in the way we provide health care. We're very fortunate in Ontario to have fabulous partners. eHealth Ontario, our primary partner to the Ministry of Health, in delivering an integrated information system at point of care. Wonderful clinicians like Mohammed that give us great advice. Partners, Southwestern Ontario and Hamilton in the hospital sector. Ontario Telemedicine Network. What we've recognized over the past what I've recognized over the past, I'm a very dangerous clinician. I'm a clinician who thinks he understands technology. The only thing worse than that is a technologist who thinks he understands orthopedic surgery, right? But the sense that, I've seen in my short career as deputy minister an enormous sense of excitement brewing. And realistically, I just want to give you a brief personal anecdote. How long do I have to talk, by the way? How long? Oh, that's a long time, so I could tell all kinds of stories. Thank you. So let me tell you when I started getting excited about technology. It was when I was working as an orthopedic surgeon. I'm a cancer surgeon by background. And I had this strange practice where I worked in a bunch of different hospitals. And I saw patients who had a condition called sarcoma, musculoskeletal cancer, kind of like Terry Fox had, right? Everybody knows Terry Fox. And these are fairly rare conditions. So frequently, I would see patients after they'd bounced around a fair amount. They would have had a lump in their leg or a swelling in their leg, and they might have seen their primary care doctor a couple times, might have seen a rheumatologist, might have seen an orthopedic surgeon and be put on physiotherapy. And then kind of 6 or 7 weeks into their course, I'd get a chance to see them be referred to me. And of course, they would have had a multiplicity of tests in a variety of places. So my typical way of seeing people was to see them in clinic and say to them, here's what I think's going on. And in the next 2 weeks, my poor secretary is going to go out and try and find all this information that's spread across multiple places. And we're going to see you back in 2 weeks, and we're going to tell you what we're going to do. Well, you can imagine their distress, right? First of all, they've been bouncing around to try to get to somebody who has some idea of what's going on. Now they finally see the guy that's supposed to be the right guy, and he says, go away for 2 weeks. Says, yeah, you've probably got cancer. Go away for 2 weeks. So, that didn't feel very good to me. It didn't feel very good to them. It actually potentially could have an impact on their outcome. So 100 years ago at University Health Network and at Mount Sinai, the great people there, and worked in information management, started to do this little interfacing thing, right? And I got to tell you, it made a huge impact on my life and my patient's life, and especially in my secretary's life, right? She was no longer out there literally driving around trying to get information. So I don't have to convince you that integrated information at the point of care is simply crucial. Shortening the period of time that we could start chemotherapy, radiation, surgery for a patient with sarcoma is pretty substantial change in their opportunity for a good outcome. Not only that, there's this funny thing that happens in clinicians' minds. It's this thing about imputing information when it's not present. And we all know as statisticians that you can impute information, and over a broad number of situations, imputing is a reasonable thing to do. But when you're making an individual decision about an individual patient, imputing is simply dangerous. And when you're missing a bit of information, and you want to get the patient into some sort of treatment protocol, you want to give them the answer to the question they're asking, what's going to happen? What am I going to do? When do I start treatment? The tendency, the risk is, if you don't have that one bit of information, to impute what it likely is based on your experience. And that's dangerous, obviously. You need the information. So, again, I don't need to convince you how important that is. I have seen in my career as a surgeon, and I've seen from my colleagues, Princess Margaret is probably the busiest cancer surgery place in Canada, one of the busiest places in the world. Wonderfully skilled surgical oncologists who all said after we started using the patient results online, the Pro device, they said, this is great to have this. It really facilitates my practice, but it scares me a little bit because I realize how frequently in the past I've made possibly, not the best decision for the patient because I didn't have all the information, right? So what you're doing, what we're doing together in creating a new model of healthcare in Canada that is driven by having integrated information at point of care, making better clinical decisions for patients, improving patient safety, ensuring, when we're talking about things like computerized order entry, that straightforward stuff about transcription safety. You know, we knew from UHN, I can't remember how long ago. Is anybody here from UHN? How long? Oh, Peter, hi, how are you? How long ago did we do CPOE at UHN? 10 years. 10 years, is that all? It seems like even longer. I remember, it seemed like 10 years to do it when we were doing it, to get the change in place.
Just over 10 years ago, we went across.
And you know, I think we all recognized at that point when we sort of did the back and forward analysis of how frequently patients got the wrong medication, they got the wrong test ordered simply because of transcription errors. So these basic safety issues that we're working step by step on accomplishing. Part of the reason that we all get up in the morning and say it's going to be safer tomorrow than it was yesterday, not only because of the availability of resources, but because we're teaching people to anticipate they're not going to impute and they won't make decisions until they've got all the information there. And I think we're at the stage where we can say that that work is far from done. It's far from done. But we know how to do it, and we will continue to chip away at it, and we'll get those basic integrated information issues at point of care underway. We know the models. In fact, in Ontario, we're fortunate that we have two models for integrated information at point of care, right? We've got Clinical Connect in the Southwest, which has been in place for some time, a point-to-point system that is spectacular. It's brought along a very nimble approach to integrated information. It's allowed folks in Waterloo, Wellington to work developing other elements of innovation that build on top of Clinical Connect. And of course, being implemented now by eHealth Ontario in Toronto and the surrounding areas, CGTA, a different philosophy, a philosophy of repository development, where, you know, patient information from the provincial lab information, the diagnostic imaging information, the information from the hospital sector, crucially about to be added, in fact, added now in Guelph, am I right? Added in Guelph, not in Waterloo, but in Guelph. And about to scale across the province, you know, dispensed and prescribed drug information. So we're a little bit behind. We're certainly behind Netcare, but we think this viewer is a good viewer, and I think it's going to be used progressively by folks. So we've got two models of integrated information at point of care, adding drug information. That's going to scale to Ottawa, to Kingston, to the Northeast, as that provincial HILE, with the support of Canada Health Infoway, gets fully implemented. And the change management, I mean, I think the build will be completed by early next year for the Northeast and for the North and Ottawa. But of course, the change management, as we know, takes longer to have it into the hospitals, to have that information coming in. But we know how to do it. We know it's coming. The versions need to be updated. Those things need to happen. The change management needs to happen, but we know it's coming. But in addition to integrated information at point of care, it starts to get really exciting now, right? It starts to get really exciting because I think we're getting close to the point where secondary use of information becomes part of the culture of healthcare in Ontario. We're still a little bit away. We got some important things to solve. One of the nice things that Ontario has done, here I give my colleagues, Alison Blair, Laurel Taylor, Greg Hine, and the Ministry of Health, huge credit, because they've thought forward. They thought forward to the personal health information protection necessary to set us up for the future, the way that we think about sharing information, the capacity we've now got in data sharing agreements, the leadership that's been demonstrated by a variety of players, by Hamilton, by London, by UHN, Sunnybrook, by Ottawa, in thinking through how to evaluate data security as we put in place integrated systems in various players across the province. But as we start to get integrated information into repositories, we start to be able to think about changing the way that we practice medicine. And I'll give you one example that's kind of hot off the presses. Our narcotic monitoring system. As an orthopedic surgeon, I got a huge sense of concern about prescription drug abuse in the province. Why do I say as an orthopedic surgeon? Because probably about 50% of the people who are suffering from prescription drug abuse, opioid dependence, got there because of poor treatment of musculoskeletal conditions. The three most common things in Ontario that lead to prescription drug abuse: musculoskeletal pain, headache, and dental pain. But, we know it's a big problem. We also know that there are potential outliers with respect to prescribing and dispensing medication, secondary use of our narcotics NMS, narcotic management system, allows us now to identify where there are deviations from, several standard deviations from the norm of prescriptions and dispensing. Now, I'm not saying that's, not saying that's bad, but it is allowing us to identify folks and allowing us to give that information, as you've read recently, to the College of Physicians and Surgeons to say, don't know if this is good practice or bad practice. Do know it's not the same as everybody else. So there's one of our early examples of secondary use of information that's being integrated in these various repositories that allows us to look at changing practice. As part of an entire suite of changes that we're putting in place under Minister Hoskin's leadership around narcotics and opioids. This is probably one of the more important ones, is looking at the way that opioids are being prescribed and dispensed. So pretty powerful start to our secondary use journey. But let me just challenge you for a moment to think about a crucial challenge, something that I think about all the time. There's an urban legend that you all know is true. That urban legend says that 5% of the patients in Ontario consume a substantial proportion of resources, 60, 50, whatever it is. And, that's of significance to those of us who work in the healthcare system in terms of that expenditure element, but also that 5% of patients are being treated very badly. That's the most important thing. We're not providing them with good care. And in Ontario, we know through recent experience with health links that if we actually identify those patients, everybody know what health links is? I don't know if people from our Ontario, health links are bringing together a variety of services with the patient in planning a comprehensive care plan that involves their doctors, their home care providers, their social workers, their community housing providers, their CAS workers. So it's President, we actually copied the model from Saskatchewan. If there's anybody here from Saskatchewan, thank you very much. Thank you. The hot spotting thing that you guys started, we've shamelessly copied. But it's pretty powerful. It's pretty dramatic. And when you sit down at a case conference and you see these various folks trading ideas about how, if we actually have supportive housing for this person, chances are they're not going to be ending up in the emergency department because they're homeless. So, these kinds of integrated care around the patient make a huge difference. And what we've done is we've looked with administrative data as to how we can identify these people. And we know now pretty much what their phenotype is, right? So using administrative data, we're so fortunate. I didn't mention when I was mentioning our key partners. Bringing together eHealth Ontario and ISIS, and that's ISIS Institute for Clinical Evaluative Science, not Mosul ISIS, okay, for those of you outside the province. Bringing together the administrative database and the opportunity for secondary use at eHealth Ontario is kind of remarkable. Let me tell you why. There are scientists at ISIS who are looking at administrative data, which is, of course, generally speaking, 18 months old by the time it gets through Canadian Institute for Health Informatics and back to the administrative databases. And they said, okay, looking at administrative databases, we can identify the trajectory of people who are becoming complex, right? So these people that you know are appropriate for the wraparound services through health links, you can actually identify using these criteria. I won't bore you with the criteria. But of course, what we're doing is we're looking in the rearview mirror. Always easy to identify things after they've happened. We're saying using 18-month-old data, we can identify there's the 5% of folks suffering from progressive frailty, suffering from cognitive decline, suffering from palliative care conditions, suffering from, in some cases, unmanaged mental health conditions, in some cases, simply tremendous social distress. There are the characteristics that define folks as being complex, looking in the rearview mirror 18 months. But you know, all the elements that ISIS has got through administrative databases now, 18 months old, we're starting to get imploding into the repositories in real time or near to real time. So what an opportunity, what an opportunity. So my challenge to you is to figure out the privacy framework, figure out the consent issues, because I got a feeling the technical issues are not going to be that hard. I got a feeling that we're going to develop very quickly as we start looking at this data. We're going to start developing algorithms that said, hey, look at the trajectory of Mr. Smith. Mr. Smith has been using services at this trajectory, and he just accelerated. I think we're going to start talking from secondary use about various trajectories of healthcare utilization. We're going to very rapidly identify a variety of patterns. This patient is becoming palliative. This patient with a long history of stable congestive heart failure is becoming palliative. We need to bring different resources to bear on that patient. Now you might say, well, that patient's already seeing a cardiologist and a primary care provider. Won't they recognize the patient's palliative? The answer is no, right? The answer is no. I'm a cancer doctor. Cancer doctors don't recognize that folks are palliative until they're very palliative. And that makes a huge difference. It makes a huge difference in cancer care. Addressing palliative care needs of folks, we've demonstrated that Cancer Care Ontario has done that work. Identifying those needs early, putting appropriate needs into place, reduces visits to the emergency department that are very distressing for patients, reduces admission to hospital, putting in place nurse practitioner house calls, makes a huge impact on the cost of care for palliative patients, and more importantly, on the quality of life for palliative care patients. But oncologists recognize that too late. And in congestive heart failure, chronic obstructive pulmonary disease, you know, my colleagues tend not to think about patients as becoming palliative. They tend to think about patients as needing maybe assessment for a heart transplant, and they think of them in a variety of different ways. And everybody should continue to have opportunities for curative medicine. There's no question. But if we can start identifying folks as progressing to a palliative track, we can start to bring other resources to bear on them. You know, Bill 41 that's currently in the legislature is designed for this opportunity. Because the sense is that by taking subregions of the province, probably about 70 subregions of the province, and we're now christening with a horrible term, LIN subregions. If we think about LIN subregions, what they really do is they tag patients with postal codes, all right? And to think about the opportunity to have a palliative care team in every LIN subregion that gets early information about patients who may be becoming palliative and has the home care resources, the community support resources to offer additional therapy to folks in a, you know, and believe me, I've seen being a part of the curative system in cancer, I've seen how people appreciate the offer of palliative resources while continuing to have access to active treatment, and how their trajectory of care changes so dramatically when that is offered to them. And I'm pretty sure the same thing can happen in a variety of other conditions that we currently, like congestive heart failure, rarely recognize as having palliative needs. So that's the challenge, is how do we actually look at this secondary use phenomenon of this data? And how do we look at data and say, okay, we know that if we look at Mr. Smith's data, we know that we can provide him with better services more cost effectively and provide him with a better outcome. But how do we do that, right? Without Mr. Smith's consent. And how do we actually get access to the data that's going to be in these repositories and apply the algorithms that are necessary to actually identify the folks that we can provide better care to? Pretty sure we can do it. I've got some ideas, but it's not right to ask an orthopedic surgeon how to do that. There are other people in this room who can do that far better than I can. But that is really an essential piece of what I think is going to be a transformation of care. And you know, there are companies that are starting to think of this, right? Is there anybody in the room from Athena? Has Athena invaded Ontario yet? Not yet. Well, you know, I've heard a lot about Athena from colleagues. And everybody know what the Athena business model is? Does everybody know what I'm talking about? No, okay, should I tell people there I should explain a little bit about Athena? So the model for Athena is they come in, especially in the evolving American medical system, where hospitals are buying practices or buying other hospitals or creating into bigger organizations. Athena's found a place. And they've said, okay, we're going to manage your revenue stream, right, which is important in the States. We're going to come into a multi-specialty practice that just joined this big hospital group, and we're going to identify opportunities to increase your revenue by putting in place work management software. And we're not going to charge you for it, I think is basically the model. We're going to actually pay ourselves from increasing your revenue stream. And the other thing we're going to do is we're going to collect this information, and their promise is we're also going to improve your outcomes of patient care because we're going to provide secondary use of this to identify folks whose A1C is off the map, who need intervention with respect to their diabetes management, whose telehome care monitoring for congestive heart failure shows their PaO2's gone down over the last couple of days. So we're going to be monitoring in the background. Now, I'm not sure to this point how much secondary use related not to billing and not to revenue, and how much related to improved care. I don't know how much of that is actually happening as of yet. But what I'm pretty sure is that with the collection of information that we can generate across Ontario now, if we start putting our minds to thinking about the opportunity for secondary use, I think we can start thinking about how we can address the issue of improving outcomes and probably reducing spending in our system by thinking about mining that data to identify real-time opportunities for improvements of care. The other potential that brings to bear is the opportunity for economic development, right? I mean, some folks say, well, why don't we go and see if we can do a co-management deal with the company and bring them here and they can start working on this data. My sense is, gee whiz, you know, we've got a system where we've got lots of good thinkers about interpretation of clinical data in this province. We've got spectacular leaders of implementation of science in this province, the Sharon Strausses, the Jeremy Grimshaws, who know how to take new models of care and roll them out through change management with clinicians. My sense is that we should be thinking through how we develop this approach to improving individual case management and potentially population health, because, you know, if we start thinking about risks in community, not just for individual patient management, but also how many people in this Lynn subregion have had colorectal cancer screening, how many of them actually would benefit from that, how many people in this Lynn subregion are likely smokers, how many of them have had access to an anti-smoking program that's evidence-based. You can imagine the way that we could start thinking about improving the health of Ontarians through this approach. So these are some of the things that currently, with the resources that eHealth Ontario, apart from anyone else, is delivering currently, the opportunity we have. But what other opportunities we have, you know? We've got the largest telemedicine network in the world, I believe. That's what Ed Brown tells me. I have no reason to disbelieve him. And as we look under Bill 41, integrating home care under LHIN, single point of accountability, what we're doing, how many people are not from Ontario? A lot, okay. So we just got a bill in front of the legislature right now that is going to try and catch up with the rest of you in a regional health authority model of care delivery for Ontario, bringing a single point of accountability for integrated care to what we call our local health integration networks. Crucially, bringing home care under the responsibility of the LHIN boards. You know, we're slow in Ontario, but we eventually get there. So we now have one point of accountability for saying, in this era where we recognize that silos exist everywhere, shouldn't we have one place that's responsible for bringing the silos together? So that's what this is about. It's not perfect, but if it passes through the legislature, it's going to put us on a course for organizational improvement, I'm pretty sure. So, opportunities that Ontario telemedicine brings us, along with some of the wonderful people who've innovated in home care to this point, I think we're probably getting close to being a leading jurisdiction in the use of telehome care for a variety of conditions. Telehome care being utilized for palliative care with telemedicine supports for families caring for loved ones in the home, as well as organizing within a palliative care network approach, house calls when appropriate by nurse practitioners or primary care providers through constant telehome care connection with loved ones in the home, through those very straightforward telemonitoring devices that I'm sure everybody's using, you know, fabulous ways of getting patients to report on their congestive heart failure symptoms, their PaO2, their daily weights, all that stuff being uploaded now to call centers where one nurse is looking after 75 or 80 patients, COPD, similar kinds of resources being available. So again, that's one of those digital resources that we know how to do it. And it's simply a question of achieving more and more scale. And in provinces as big as Ontario, where regional issues become so important, you know, taking that expertise of telehome care. I was talking to a primary care provider who was doing locums in Northwest. I was talking to him yesterday morning. You know, I had this experience when I started practice. I was a locum doing emergency medicine care in Peterborough, not far from here. And how many of you know the 35115? Yeah, 35115 has now got a divider down the middle. It didn't used to, right? It used to be one of the most dangerous highways in the world. So anyway, you'd be there in the emergency department, and suddenly you'd have 5 trauma patients arriving. So that, like 4 years later, I'm in orthopedic residency, right? Sunnybrook, and the trauma team would be called. You'd have 5 surgeons arriving for one patient. Well, you know, in outlying Ontario, and we got a big region, you got 1 doc and 5 patients. So we have teleresuscitation resources, telecritical care resources. So Sudbury's doing a terrific job. This doc who had been doing a locum at Manitouwadge said to me, this was spectacular. He and his wife were doing, his wife was president of the community. She came in to help him. He was on call. Several victims arrived, and they had Sudbury Hospital critical care and surgeons there, telecritical care, teleresuscitation, supporting them and stabilizing these patients and then shipping them out. So we need to keep pushing these resources along, right? We need to keep pushing the things that we know create impact. In fact, thank you so much, Michael. Michael's recently done an assessment of value created across the various digital resources that CHI has put in place. I think $16 billion of benefit for the entire country. And we're recognizing currently, through a very limited evaluation of our digital health resources, $900 million a year of benefit realization from very concrete stuff like, because of telemedicine, that patient had a consultation by telemedicine as opposed to flying in our travel plans, or because of telehome care, we've got one nurse looking after 45 patients as opposed to one nurse in a day being able to see 5 or 6 patients through our standard home care mechanisms. Through very straightforward measurement of value, without even considering the reduction in error that we know is one of the most costly things, the investments that you're all driving in our system create huge value. We can already say, I think we estimate, I don't know if anybody from eHealth Ontario is here, but we estimate our expenditures something like just over $800 million a year in all our expenditures in hospital systems and in the work that eHealth Ontario is doing. So we estimate that we're probably exceeding currently what we're expending in digital investments in benefit realization through a really minimal measurement of benefit realization. So in a big province like Ontario, where we've got remoteness challenges, we've got equity challenges, because what better way to serve the folks who have the least equity of health service provision in the province, Indigenous Ontarians living in remote communities, putting in place more remote resources as well as regular clinicians that they can get confidence in providing them with advice would be a pretty spectacular way of thinking about how we can solve some of the health equity issues present in Indigenous Ontario. So these are all the opportunities, right? And you know these opportunities. I'm telling you what you know. So what do we need to do to accelerate this? And what are we doing in Ontario to accelerate it? Well, I'm lucky. I got a minister who gets this. And when we started working, Minister Hoskins and I started working together on this, he said, trouble is in Ontario, we've got, first of all, we've got a very limited healthcare strategy. Nobody really knows what our healthcare strategy is. And we sure don't have a digital health strategy that anybody can recognize. And if we do have a digital health strategy, it's a digital health strategy to advance digital health goals, as opposed to a digital health strategy that advances healthcare goals. So that's probably the most important thing that we're currently doing in Ontario. So we're saying, okay, we've got a healthcare strategy. We call it patients first. It's a good thing, right? Patients come first in a healthcare strategy. And we've got a way of reorganizing care that I've mentioned briefly. It's called Bill 41 with a focus on primary care, recognizing that any high-performing health system in the world invests in primary care. Patient-centered medical home is the model that we want to implement strongly as the foundational model provided by nurse practitioners, provided by primary care providers. We think that we're further along on that than any other Canadian jurisdiction, and we want to push that further. So that every Ontarian is rostered to a primary care provider who provides comprehensive care within a regional model of care where it's easier to connect to home and community services. And you can look online, you can see our Patients First strategy that's based on moving care out of the hospitals, just as the same as everybody here is doing, recognizing frailty at an earlier stage, and trying to bring these integrated resources present currently in hospital settings and moving them into the community. So that's our patient strategy. That's our healthcare strategy. And what we're currently doing is aligning everything we're doing in digital health against that. So really important for us to think through primary care and the resources that are available. We're proud that over 80% of Ontario primary care providers have electronic medical records. We know that we need to start connecting the information in those electronic medical records to the repositories, to the EHRs, to the health information exchanges, whatever you want to call them. The integrated systems, we know that there's huge information present in EMRs. We're not sure how we're going to do that, but we're hopeful over the next couple of years. We've got a bit of a plan to get that done because that information is going to be crucial. Also, looking at how we can help primary care providers with better utilization of the resources they have. And we're also lucky, some of you from Ontario may have heard that we've got a little disagreement with the Ontario Medical Association now. Some people may have, we don't have an agreement really. So, it's a little tricky for us right now to talk about how we're going to provide better resources and how we're going to fund better resources for physicians to use in their office. But we're very lucky. We're very lucky in that Ontario MD, Sarah Hutchinson's organization, is a great partner. And the one thing I know we cannot do right now is say to primary care providers in Ontario, trust us. We're the Ministry of Health, and we want to help you. Whereas Ontario MD, which is owned by the Ontario Medical Association, has terrific people working, has the same goals that we have to help physicians in primary care not only use their EMRs as record-keeping tools, but to help to evolve their practice and to enable their practice. And that's a partnership that's crucial for us going forward. Until, the OMA, and I was just talking to Virginia Wally, we were just on a panel together before I came over here, trusting that this relationship will improve. And as we look to patients first, to Bill 41, and the investment in primary care in this province that we know we need to make, that's a long game for us. We know it's not going to be easy with the current relationship we have with the OMA. It's going to take a while to get that going, but there's lots to do. And we've got doctors of goodwill, not who, look to the government to be generous, but rather look to the government as a partnership that in some ways is working in their interest. At least we hope that's the case. And we know that'll be the case going forward. We will solve this problem sooner or later. So the other piece of the strategy that I just want to mention to you, very focused on home and community, very focused on integrated care for all providers. So one of the really crucial pieces of this repository is we've got the wonderful system developed by the Ontario Association of Community Access Centers, the CCACs, Community Care Access Centers. It's called CRIS. That is present on the integrated system, and it has some wonderful care coordination tools on it. So this is one of the things, along with medications, that I think is going to increasingly attract primary care providers to use this integrated system of point of care, to use the Health Information Exchange Viewer, is the fact that they'll get drug information and they'll get community care information on this. So having that part of the information system in integrated fashion is an important piece of the strategy. The final piece of the strategy I want to talk to you relates to hospitals. And, Ontario hospitals all have hospital information systems. Predominantly, if you look across 140 hospitals, probably Meditech's the biggest provider, probably Cerner the second biggest, Allscripts is present, Oasis is present, Quadramed is present. Some of these names probably have changed since I last remember using them. Epic is starting to come into the community. And we've had an interesting approach. To renewal of hospital information systems. What we've said is we've said to hospitals, anytime they want to go out and purchase a new system or renew a system, we said, you have to go out and do an RFP, right? Now, how can 140 hospitals possibly have the capacity to go out and do an RFP? I know from my experience, ladies, how hard it is to do an RFP, right? And to anticipate every hospital in Ontario being able to do an RFP, difficult to think that is possible. So, we've gone to Treasury Board now. We've got great advice from a hospital information system panel led by Murray Glendenning from London Health Science and Donna Cripps, who's the CEO of the Hamilton Lynn. And they said, we need to start talking about hospital clusters, about renewing hospital information systems, not one at a time, but rather get a strategy for how we're going to do this across several hospitals. And not talk about hospitals only trading information through repositories, through point-to-point interfacing, but rather talk about clusters that invest in upgrading together. So we've now got the ability to do that, to develop the strategy that will underlie hospital clusters. Now, it's easy to say that, right? It sounds great. But the corporate governance of clusters, and especially the clinical governance of clusters, that's going to be tricky. But I've got a feeling that we'll be able to figure that out because there's tremendous pressure across the hospital system world to renew systems, to upgrade systems. We've seen some very attractive opportunities out there. And if we're going to do it in a rational way, the only way we're going to be able to afford it is by this cluster approach. So that's part of our strategy as well. So I see I've got 5 minutes left on the clock. Can I save 5 minutes for questions? Is that okay? So for those partners who are here in the room, OTN, EHO, Ontario MD, the hospitals of the province, the CCACs, I'm sure I've forgotten someone. Have I forgotten anyone? Shout out. partners for us. You know, this digital health adventure is really exciting. It aligns for us with delivery of the health system. It aligns with a focus on patient-centered medical home that's been missing in Ontario, focuses on primary care and home and community care. And it says if we're going to accomplish this, we need to focus on these digital resources. So thanks to everyone in the room that's partnered with us and working on this. And I'd be delighted to take questions if that's appropriate. Thank you.
Well, thanks very much, Bob. And, you know, it's a great speech. We, you know, value your leadership very highly at Infoway. Ontario is a major jurisdiction, and we're very excited about the strategies you're putting in place, both for healthcare and also the digital strategy, and we want to see how we can help with that going forward.
You know, and just let me say, because when I mentioned partnership, here I am at a CHI conference, and I didn't mention enough how we appreciate the partnership, not only the funding, but also the intellectual development, you know, and also the fact that some things that Infoway can do, nobody else can do. So e-prescribing, probably the best example, the investment you're making in telehome care across the country. These are things that are absolutely strategically essential and only CHI can do. So thanks for your leadership,
Great, well, thanks
Michael.
very much. Thank you, and pleasure to do that. So I was interested, Bob, in having a little bit about your views of patient access to information and tools. I've seen recently that there's a couple of initiatives, one by Medcan and another one by Akira, where they're offering private access to video consults. And I would wonder, when you look at some of our other provinces, Nova Scotia, Alberta, Saskatchewan, are taking an approach where they're looking at a single kind of patient portal for the province. Is this a kind of strategy that could work in Ontario, or do you favour a multiple portal approach, or are you looking at the private sector to step up? How do you see patients getting better access to systems in this province?
Yeah, thanks, Michael. And I didn't talk about the consumer aspect of, you know, Minister Hoskins' thinking around this, which is a huge part of it. So a few things. Boy, you just brought up so many issues. First of all, the portal issue. I saw Saskatchewan's portal yesterday, the TELUS portal. Looks great. They've got it out for 1,000 people. I know that the MyChart portal that Sunnybrook has now been adopted. I think we're up above 200,000. Anybody from Sunnybrook? Is Sam in the room, or anybody from Sam? I think we're above 200,000 people now using the MyChart. I got a sense that Ontarians need access to their information without charge, not through a private resource. You know, your question, do we have one portal or three portals? I don't know the answer to that. We need to assess that. But I think that's probably going to be considered to be part of publicly funded healthcare, is access to your health information. You know, I'm fortunate working in the cancer world. Patients have had access to PMH charts through a variety of ways for a long time. And, you know, people don't get upset. They don't get, you know, frightened by what they read. They manage their information. They don't bug you like crazy. It's a very important part of the patient-provider interface that we're currently not providing. That was question number one. Question number two, you know, how people use the system. Currently, I mean, we all recognize how shameful it is that people can't book appointments by email. They can't, you know, interact with their providers. Peter Vaughan's been a leader of this in Nova Scotia. Their recent agreement with the Nova Scotia Medical Association includes digital care. Peter says, don't call it digital care. It's not virtual care, it's care. And we all know about, you know, Kaiser providing, 60%, reducing their patient touches by 60%. That's got to be part of our future. OTN is currently working with something Elephant. What's that? Wise Elephant? Wise Elephant. They're working with Wise Elephant to look and see how patients can download apps that allow them to, and probably my mom has been doing this for 5 years. That's why I usually find out. I think it's innovative. I find out he's been doing it for 5 years. But, you know, we need to be able to provide this. We have a bundled model of physician compensation. And undoubtedly, there's a provider in the room who's going to tell me I'm wrong. But if we were simply to say, okay, that bundle of comprehensive care that we're paying you a flat rate for, if we say you can do that and work on that with e-consults, you know, with e-communication, I'm pretty sure that we can build this in. As far as the concept of, UberDoc, right? dial up a consult. So I'm opposed to that totally. I don't think it's comprehensive care. If people want to pay for that, fine. My philosophy is, and I know Mr. Hoskin's philosophy is, that's not part of publicly funded care. However, we also recognize that all our kids don't want to wait 2 days to see a doctor. They don't want to go to the doctor. They want to have access the same way they get Uber access. So we're going to have to think through within a comprehensive care model. The primary care docs, in terms of the model of the patient-centered medical home, I'm sure are thinking about how they're going to do this. And like I say, probably the Waterloo Innovation Center, they've been doing it for 5 years, and we simply have to find out what they're doing. But those are great questions. Consumer access is what we're not going to build apps. Okay, and the Ministry of Health has no business doing that. We need to provide a portal probably. In terms of the variety of different things that a repository provides us in terms of access to diabetes care, to a variety of things, you know, that's not our business. That's other people's business. We may fund some of it, but it's not our business to build it.
Okay, thanks very much.
Thank you, Michael.
Hi, Bob.
Lydia, how are you?
I'm well. How are you?
Good. Excited, as you can tell.
I am very excited about your comments today, and you had me at secondary use. So can you just describe how we're going to break that logjam, Bob, and what can we as the people in the room, provider sector, help? How can we help?
So I'm not even sure there's a logjam as of yet, because I'm not positive that we've got all the information that really enables us to think about secondary use. But you know better than I do. But so where I think this starts is it starts with where all healthcare starts, and that's in primary care. And what do I say? Well, first of all, primary care information is important. Secondly, if we're going to get into a situation where we can actually do secondary use for Mrs. Smith, we need to get her consent, right? And I don't know how we're going to get her consent unless we're doing it from a primary care perspective. Maybe I'm wrong. Maybe there's another way of doing it. I don't know the answer to that. But that, to me, is the biggest issue. Protection of personal health information is going to be crucial, obviously. But, we've got ways of de-identifying information. Ontario's good at that. But this isn't de-identified. This is personally identifiable, linked information. So PHIPAA is going to be crucial. And so I don't know the answer, but please start thinking about it, all right? Because I think we're getting the resource together. I think EO's got the resource to start thinking about it. I'm not sure in Clinical Connect if we can do it until we get into a repository. My prime teacher on this is nodding no. So that's a good reason for us to bring Clinical Connect information into a repository. But boy, isn't that exciting to think about that? Like, is anybody not excited about thinking about how we can actually use that? So I'm just thrilled by it. So help, sir.
Deputy Minister, thank you for coming. My name is Brian Penner. I'm a patient from Manitoba, and I have some questions. And I'd just like your input on it. Everyone who works in the healthcare system has a special interest group representing them. Doctors have the Ontario Medical Association, nurses have the Ontario Nurses Association, and the Registered Nurses Association of Ontario. The Ontario Hospital Association represents the hospitals. Who represents the patients?
I think I'm supposed to. That's a great question, but I think that's, isn't that the role of the ministry? I don't know. Healthcare in Canada is so interesting, right? It's so political. Like, no matter how you organize your healthcare system, something goes wrong, the minister's on the front page above the fold, right? Certainly it is in Ontario, I'm sure it is in Manitoba, so it's political. And in some ways, that's good, because it means that you get to vote, right? You get to vote on how the healthcare system evolves. And I don't think we've thought, Ontario is interesting. So a couple of years ago, we used to pride ourselves that we were never in question period. Health was never on the front pages. We had an election. Health wasn't even mentioned in the leaders' debate. Then we realized maybe that's not so smart, right? Maybe we want people to be thinking about health services and how they're delivered. So, when we did Patients First, we put it out for public consultation for 3 months. We got enormous numbers of organizations, OHA, RNAO, yes, all those groups. We got huge numbers of responses, 7,000 responses from individuals. Canadians care about healthcare. And I think, you know, the role of the Minister of Health is to represent the patients.
Thank you.
Thanks, Brian. I appreciate that question. So you tell me when I'm done. One more question?
Thanks, Dr. Bell. Greg Webster from Ki-Hi.
Hey, Greg.
I just wanted to comment on the secondary use opportunity. Really appreciate your call to action around data timeliness there. I just wanted to let folks know within Ki-Hi, we can actually, from the time data is received, turn it around and get it back out within 15 days. And we've actually changed some business processes so that can actually be within 24 to 48 hours now. So that can support a lot of good secondary use activities.
Yeah, sure can.
One of our challenges here, I think, is to work together so we can automate data flow into organizations like Ki-Hi, and we can get it out quicker to the ministry and to groups like ISIS.
Thank you, Greg. Yeah, that's, you know, and to have standardized information that Ki-Hi provides, comparative information available in standard format is crucial. So thanks very much for the opportunity, Michael. Thank you for the invitation, and enjoy the meeting.